Good afternoon, ladies and gentlemen. My name is Jilich. I'm a HIV clinician based in Prague, Czech Republic, Charles University. It is my great pleasure to join this wonderful meeting today. My job is to share with you a few case presentations focusing on long-acting antiretroviral in people living with HIV. So this is my disclosures. You can see them. This is my first case. So 32 years old male diagnosed in 2021 with pretty nice immunology, more than 600 CD4s and HIV RNA over 44,000 copies. We put him on a first antiretroviral regimen consisted of TAF, FTC, elvitagrivir. He was also on the rosuvastatin 10 milligrams a day. He was absolutely satisfied with this single tablet regimen, but through the time we start to speak about a potential switch to long-acting antiretroviral therapy. The baseline resistant main already in May 21 found no RAMs, so no RAMs against RTI, protease, and integrase inhibitors. His subtype of HIV was B and BMI 23. So he fulfilled all the criteria for the switch to CAP-LA. And his first application of cabotegravir long-acting was on the 2nd of October 2023. Until now, he's got 6 doses of this long-acting regimen, and he's absolutely happy about this regimen. There were no serious injection site reaction, just for a few times a mild local pain and swelling. And this case is representing the vast majority of our cohort being on CAP-LA long-acting. My second case is my very first patient on CAP-LA rilpivirine LA regimen. She's a female patient being 46 years old. He was diagnosed pretty a long time ago, more than 20 years, in 2022, and she's slow progressor. Vast majority of the time, she was not on antiretroviral regimen, and she prefers to keep on that. But I tried to persuade her to start antiretrovirals around 2016. And until now, she had a total number of 3 regimens. The last one consisted of TAF, FTC, and rilpivirine. She was always struggling with the adherence of the therapy, and she was not very good adherent. But therefore was the main reason why we started to speak about a potential switch to long-acting regimen. Many months it came first to our market in Czech Republic. But she was, as I told you, our first patient. So the first application was 22nd of March 2023. She was very motivated to keep on that regimen. She's very happy about it, and until now she's got in total 10 doses. Also in her case, the injection site reaction were mild or maximum to moderate, lasting for 1 or 2 days after the application. My third case is a very young male patient, being 22. He was diagnosed 1.5 years ago in 2022 with a very high amount of CD4s, 853. The percentage was 37%, and the HIV RNA was quite high, 350,000 copies. His first regimen was a single tablet regimen consisted of DTG and 3TC. As all our patients, he was also tested at the baseline for resistance in September 22, but unfortunately there was a finding of K103N mutation, and his subtype was the B subtype. He was on the DTG3TC well suppressed, less than 20 copies per milliliter all the time. He was very adherent, but especially due to the comfort aspects, he was asking me about a potential switch to long-acting regimen when it appears in Czech Republic. But as we all know, and you can see on the right-hand side of my slide, the part of the SNPC of vocabulary and recambis it's a mention over there that there could be no mutation in a class of NNRTIs nor integrase inhibitors found or presumed in any candidate patient. So therefore, I have to tell my patient then he's not indicated for long-acting regimen CAP-LA. My fourth case is a male. He's 43 years old, well-educated guy. He was diagnosed back in 2017. His baseline CD4 count was 521, in percentage 18.8%. The HIV RNA was very high again, 297,000 copies. It's all, we are testing all our patients at the very beginning of a follow-up care. We tested also this guy for resistance in September 2017, and there were no RAMs found against reverse transcriptase, protease, neither integrase. His subtype of HIV was B, and he was obese, and he's still obese. The BMI is around 29. His first regimen was the abacavir, 3-TC, and dolutegravir as a single tablet regimen. He was very well adherent, but the pill is a little bit bigger than usually, so therefore we switched to the DTG 3-TC also in single tablet regimen. But he's very interested in HIV. He's reading all the news, and he was asking me actively about the potential switch to CAP-rilpivirine LA. He fulfilled all the criteria, and his first application was on 11th of July 2023 last year. In 2 months, we checked the HIV RNA, and we were very negatively surprised seeing the amount of 230 copies. We made in 1 month a measurement once again, and wow, there was more than 6,000 of copies. So we made another testing against resistance. There were no RAMs against PI and NRTIs, but unfortunately, as you can see on the slide, K101, E138, and G140 and Q148 against integrase resistance. So we switched him to TDF3-TC and darunavir regimen. He was resuppressed successfully, but this is showing us the pros and cons of the newly coming CAP-rilpivirine long-acting regimen. So that's it for from my side for now. Thank you for your attention, and I'm very happy to take all the questions and discuss within the Q&A session all other details of those my cases. Thank you, and enjoy the rest of the meeting.